All right. That's good.
Okay.
Okay. All right. Thank you, Diane. Thank you, NeuroChallenge, for giving us the opportunity to discuss some potential new treatments. It's very, very exciting. Um, Let me tell you a little bit about myself. First of all, I'm with Bradenton Research Center. Been here for 9 years or so now. I am a family medicine doctor by trade to begin with. Did urgent care for a long time. Went to school in Texas, and been doing always been interested in research since college, and it's been a great opportunity to be able to start doing some pharmaceutical research here. Let me tell you a little bit about research to begin with. What we're talking about is clinical trials. First of all, it takes years to get these medicines to market in order for your physician to be able to write a medicine for you, for the prescription. They all have to go through clinical trials. And these trials all start out with phase one. I'm not a big fan of doing any sort of research on animals by any means, but these pharmaceutical companies a lot of times will test these new medicines on animals first, and then it moves on to humans, and there's different phases that they work out. First, they'll start with just a small number of people, and then it gets to larger numbers where sometimes we're involved in research studies that will have over 10,000 people in it. Um, the main ideas of these, as far as they're concerned, number one, you have to make sure that the medicine is safe. Obviously, patient safety is the number one priority. And the second thing, you have to make sure that they work. You have to make sure that these medicines are actually doing what the pharmaceutical companies say that they're going to do. So you see on the news quite a bit sometimes new medicines coming out and they have to be FDA approved. Well, that's not just for the United States. The studies that we work on have different protocols where they're looking for a particular subset of patients. And sometimes it's a very small subset of patients. But anyway, we follow these protocols that they have to use in Japan and China and Australia and the EU, over in Europe, Canada. All these different areas have different ways to get medicines approved. And that's why sometimes you'll see that medicines are approved in Canada, but not in the US or in the EU, and not in the US, or vice versa. Sometimes the FDA will approve things before they do in Europe. So it's a process definitely to get these medicines approved. But you can rest assured that it's not just Bradenton Research Center. It's not just the state of Florida. It's not just US. 99 times out of 100, we're dealing with medicines that they're testing in 50 places in the US and 300 places around the world. It is important to note that most of these are placebo controlled, which means that we have to show that this subset of patients did not get the medicine while this one's did and these ones did, and that it's that the outcomes are different for the people that got placebo and for the people that got the actual medicine. And the OLEs that I mentioned here are open label extensions, which most commonly happen at the end of the studies, where if patients did get the placebos, they would be guaranteed the medicine at the open label extension. So you may get a placebo to start out with for 16 weeks or for a year, maybe even, but then you'll be guaranteed the medicine for a year or two after that. These are, of course, all voluntary. These consents to get into these types of trials can be a little overbearing, a little scary when you look at them. Sometimes they're 20 or 30 pages, but you can rest assured that nobody is stuck in a clinical trial when they agree to it. you can sign a consent, and when you get out to your car or the next day or the next month, you can say, "Nah, I'm not really interested in it anymore." And people drop out of trials for all kinds of different reasons, for different family members getting sick or having to move or whatever else. So you never feel like you're stuck in a clinical trial. Um, and you're not only helping yourself most of the time, but you have to look at the way that, if you do get involved in a clinical trial, you're getting this medicine to market where it can help millions of people around the world. So it's kind of exciting to be involved in something like that. I'm going to go through real quick the clinical trials that we have right now. We've been a research center for over 25 years, and we deal a lot with neuro things, but also with other things as well. Parkinson's is a big one. Alzheimer's is definitely a big one. In the pre-Alzheimer's, we've had a lot of studies with pre-Alzheimer's before patients start having symptoms. And I don't know if you saw in the news this morning, they're coming up with a new um, blood test for Alzheimer's that we've been using for a while through Lilly, one of the big companies. But it should hopefully become available to people in the United States at some point here, where your doctor will be able to write a prescription to get this blood test, just as if you're testing for your cholesterol or your glucose to see if you have diabetes. Hopefully at some point there'll be easier tests for diagnosis with Parkinson's as well, besides getting a DAT scan or something like that. Right now, you have invasive skin testing and DAT scans, but it would be nice just to do a blood test, and even if to figure out like a pre-Parkinson's test before patients start having symptoms would be fantastic as well. But right now we have trials for Sjogren's, myasthenia gravis, lupus, depression, anxiety, MS, a stop cancer trial, a Parkinson's trial where we do blood and spinal fluid collections and send it off to like 50 different labs around the world that will save it and do certain tests on it. It could be 10 years later, but they know that this spinal fluid and this blood is from someone with Parkinson's. I should mention also we have approval by the DEA to do Schedule 1 trials, which means that we can work with marijuana before, and also with MDMA, other types of Schedule 1 drugs, which are maybe you can say like Schedule 1 psychedelic types of medicines, and I can go into that later if anybody has any questions. I'll go into Parkinson's real quick. 500,000 people diagnosed annually. Obviously, most of you can understand that you think, gosh, I had Parkinson's for the last 2 years and nobody ever diagnosed me. That is super, super common. It's not an easy diagnosis, unfortunately, and it can be so easy to say, oh, well, your people are just getting old, or you're having this problem or this problem. Unfortunately, a lot of people are misdiagnosed or undiagnosed. Obviously, dopamine is a critical hormone. I'm going to talk a little bit about alpha-synuclein, which is another protein that we're looking at now in the roles of research as playing a huge role in the development and continuation and the expanding of the Parkinson's symptoms. We'll talk about that a little bit later, but and fibrils also play a role with Lewy bodies. You've probably heard of Lewy bodies before. Lewy bodies, they believe are the end game as far as the beginnings of this alpha-synuclein protein that gets kind of bound together and can stop the synapse and the dopamine from transferring the way that it should. It's nice now, 5 years ago, we weren't looking at this alpha-synuclein and these fibrils as an actual issue, but now we're able to take a look and actually look at some treatments for these these type of proteins, which we believe now are causing the cell death and the loss of function with these with that getting that dopamine across that barrier so you can continue the regular motor movement. I should mention at this point, we've come so far just in the last few years, but we're always finding out new things, and we're always looking at different avenues for treatment because just like Alzheimer's, diabetes, all these other different types of different diseases. Unfortunately, it's not that simple. And y'all know better than anybody, people that present with Parkinson's, some can have such terrible tremors and some have no tremors. There's no one Parkinson's patient that is the same as another one. So everyone presents in a different way, and that causes not only the diagnosis issues, but also the treatment issues, because there can be so many different things at play. So it's nice to take a look at this side and slide and see not only new potential options for symptoms delay. So I'm talking about stopping the progression, but also actually some disease modification, which we have not been able to talk about for years. The carbidopa, levodopa, which we'll talk about in a minute, is more of just a Band-Aid, but actually slowing the symptoms and stopping stopping the progression and actually going back in disease and modifying the actual disease itself is very exciting to talk about. And talk for a second about some preventative measures. They have noticed now, and they're still finding out all kinds of different types of genes that are involved. 15% of people have a previous family history, but a lot don't. But these genes, as they play a role with a lot of other different diseases, they're finding new ones now that are associated with Parkinson's. And different ones can be associated with different aspects of Parkinson's. As we said before, not only the start of Parkinson's, but also the progression, and these genes can play different roles as far as where you are in the disease. I mentioned here the Stop Cancer study down here. That's one of the studies that we have where we're actually testing 41 different genes that are associated with different types of cancers. So it's a simple mouth swab. And if you have had cancer or and an immediate family member, you can come in and get a mouth swab, and you get a result back that has, if you are positive for 41 different genes that are associated with these different types of cancers. And we're talking anything from breast to colon, prostate, all kinds of different cancers. But at some point, hopefully, we'll be able to have some sort of a test like this. It'd be fantastic, not even a blood test, but a cheek swab that would let us test for these different Parkinson's genes and give us an idea of, first of all, the chances of somebody coming down with Parkinson's, and also maybe new onset or early onset Parkinson's, which, patients, in their 40s and early 50s getting Parkinson's. All of these genes are being discovered, where we can actually maybe test for these and get an idea of somebody in their 20s if their chances are higher of coming down with Parkinson's and these other cancers and other diseases as well. And at the bottom here, you notice genome editing, very exciting treatment modification, and actually a modification for this as well. It's called a CRISPR, and you may have heard of this before or seen something about it. But essentially what they're doing is they're taking some of these cells from Parkinson's patients and other diseases as well. They are modifying them by taking out these certain genes and replacing them with other genes. And then the patient is getting this blood transfused back into them. And the idea is to get rid of these genes that may be causing these issues with these normal genes. And you can say, yes, it's invasive because you have your blood drawn to begin with. They modify this blood and then they get it back to you. But it's something out of science fiction. If you think of even 10, 15 years ago, you wouldn't think of some sort of a modification like this. But there's a place in Orlando that is going to start doing this. And it's really exciting because it's something brand new, and just the ability to maybe stop this disease in its tracks or even before it happens is very exciting. Also, other risk factors for Parkinson's we can talk about briefly. Gradual exposure, not only to the gene mutations, which can be from birth, but also air pollution, pesticides. They've looked at as something as very important. People that live up in Iowa or Indiana, Illinois, have been around a lot of pesticides and that. The second point here is the GI system. And some of you may have heard of this before, but they've actually been looking at giving antibiotics to patients that have just come down with Parkinson's or who are at risk of Parkinson's by certain genes. But what they're thinking is that certain bacteria in the gut is actually traveling up, getting into the mouth, actually passing the blood-brain barrier and getting into the brain, and different actual bacteria possibly causing or kicking these genes into effect where they start mutating, but possibly looking at that as being preventative or stopping the progression of Parkinson's by giving actual just routine antibiotics to stop this bacteria in the gut. There hasn't been a lot of research on that, but that is something that they're looking at, which is kind of exciting because that would be obviously pretty easy and well tolerated. I should mention also that any of these treatments that I'm talking about I didn't make a slide for this, can easily be found on a website, and it's clinicaltrials.gov is what it is in the US, and clinicaltrials.gov has all of the trials listed, and it's searchable by putting in Parkinson's or putting in Alzheimer's or putting in specific medicines. It's searchable by that, and all of the trials that are going on in the US come up, and it's a great website. I'll say it again at the end, clinicaltrials.gov, but it's a great website just to take a look. And it also a lot of times will tell you what studies are going on in your area as well. So you can search all kinds of different ways. And I should mention dietary patterns here. The MIND diet is a type of Mediterranean diet that you may have heard of. And that has shown a 13% reductions in Parkinson's risk. And with they're looking at it with Alzheimer's as well. But it's pretty straightforward Mediterranean diet: vegetables, fruits, whole grain bread, cereals, beans, nuts, seeds, fish, seafood. You've probably heard some information about that before. Let's talk for a second about carbidopa-levodopa. Obviously, this is a medicine that most of y'all are familiar with. It is more of a band-aid than anything. It's not disease modifying, doesn't really fix anything, but it helps get that dopamine across where it needs to keep up the strength, and helps with the tremors. the carbidopa is a decarboxylase inhibitor that goes along with the levodopa. And essentially what it does is it just helps keep that drug around a little bit longer so it can make its way into the brain and get it to where it needs to go. It's nice that these medicines are oral. You don't have to get injections, infusions, or anything like that. But they're looking at the carbidopa levodopa as a modality of getting it that way as well instead of the oral. Obviously, the oral is easy, but as I'm going to talk about here with this new drug, IPX203 doesn't actually have a name yet, as most of them don't. But it's kind of exciting that it's a new reformulation of the carbidopa levodopa that you may get access to at some point. And I mentioned here the USF Department of Neurology, but this was tested all over the United States, just the way all of these drugs are. But what's interesting about this is that it's the same type of medicine, but it's actually divided up into instant release granules, which is kind of the way that the medicine is now, and also the extended release coated beads. So it's still oral, but these extended release beads will let this medicine stay around longer. So it just as you've seen with some high blood pressure medicines and some glucose medicines, you have the regular medicine, and then you have the extended release. Well, this is, you can say, is kind of a combination of both for the carbidopa levodopa. And the exciting thing about this is that it lets it stay in your gut a little bit longer. It doesn't disintegrate as quick, and it gets more of that medicine up to the brain where it needs to get to. All of these research studies have primary and secondary endpoints we can talk about, but as far as this one for this new IPX203, you can see there that instead of having to take the regular instant release carbidopa levodopa 5 times a day, patients were able to take this medicine only 3 times a day, which I know a lot of you can appreciate. Even 2 times less, without having to set an alarm, without having to go through these off times, makes a huge difference just in your daily activities. I mentioned here the change from baseline to off time is super important. I think most y'all are familiar with off time. That is when your medicine is worn off and it's not time to take your new dose yet. There's several different things that you can do about this. You can only take the carbidopa levodopa so many times, because then you get the symptoms associated with taking it, say taking it too much. But with this new medicine that has the extended release, to be able to take it only 3 times a day would be definitely significant. And I know most y'all who are taking it 5 times a day can agree with that. The secondary endpoint, which I think is very important, is your PGIC score, which is essentially how patients are rating how they are doing and how they are feeling. Now, with all of our trials, we have subjective and objective types of ratings that we look at. And one of them is a PGIC, which is essentially patients rating themselves. Are you worse? Much worse, about the same, a little better, improved, much improved, very much improved. And you can see here, taking this medicine, 70%, almost 30% said they were much improved or very much improved. So super exciting. That's patients rating themselves. That's with taking out everything else. That's just them saying how they're feeling and how they're reacting with this new medicine. Obviously, there are some limitations with the carbidopa levodopa. One thing is that people can become, well, first of all, can have a little immune suppression with a lot of different medicines. They can, increase your chances of having colds or COVID or other things like that. But obviously that's part of the risks that you take with a lot of medicines. The second thing is loss of functionality. I don't have to tell you all that you might have started out taking it 2 times a day, then 3 times a day, then 4 times a day. That's a huge benefit of this new medicine, hopefully only 2 or 3 times a day. But and I also mentioned that they're looking at that this medicine doesn't stop working, but a lot of times with the disease progression, you can have new or worsening symptoms that the drugs just cannot treat as well. There's some inhaled apomorphine that we've worked with. I'm not sure how many of y'all are on apomorphine and know exactly what that is, but this is a huge advancement just in the last year or two. And we actually had this study here. Apomorphine is a medicine that you'll take when you have those off times. It's an injection, it's invasive, and yes, obviously it hurts. It's kind of a pain to do, but it helps you get past those times when you start having the Parkinson symptoms again, but you can't take your medicine yet. So if you take it, let's say 4 or 5 times a day, and you may have several hours of off time where your medicine's just wearing off and you can't take that medicine again yet. This inhaled apomorphine that we had was very interesting. It first of all was a new way for inhalation medicines. A lot of you may be familiar with these puffers that you can take for asthma or COPD, and you kind of have to breathe out these large breaths, and then you have to time breathing in, and you have to do your puffer at exactly the right time, and you might not get much of the medicine or anything like that. The way that this medicine was inhaled was a new type of electronic inhaler, and it's a little bit bigger than a puffer, and you have to charge it, but you don't have to time anything. You don't have to take these huge breaths, and you just put it up to your mouth and you just breathe in as you normally would, maybe a little bit deeper if you can. And you got in like 98% of the drug, just as good as you would if it was injected. So really good method to get this medicine in, and they're using this inhaler to for other types of medicines, benzodiazepines, and also for diabetes, some diabetes medicines. But hopefully that will come to market at some point where it will be a lot easier to use these inhaled medicines. And it definitely, first of all, it worked very, very fast within 10 minutes, and it decreased these off times that patients were having significantly. We're not doing that study anymore, but as I said before, these studies come and go really fast, but very exciting. First of all, being inhaled, and secondly, an easier way to use that inhaled, and getting rid of some of these off times. Let's see. Okay, this is talking about a new type of medicine. These are actually 2 medicines that are very, very similar. UCB 0599 and 022. This is the chemical structure. It's oral medicine, which obviously is very handy. You see the name of it. This one actually has a name already, which is kind of exciting. They start giving them names instead of these numbers when they start getting closer to the FDA submission and approvals. But anyway, that's the chemical structure, and it's nice that it's oral, and it's nice that it passes the blood-brain barrier easy, because a lot of these do not pass that blood-brain barrier easily if you take it by mouth, obviously, because you have all the acids in that in your stomach. The infusions obviously are easier, and the inhalations are easier. But both of these work on the alpha-synuclein. And this goes into a little bit about how this works. Um, this is a potentially disease-modifying medicine. We had a study started about a year and a half ago for brand new Parkinson's patients that could not have been diagnosed for more than a year. And now the study that we have is using the same type of medicine for patients who have been diagnosed for at least 5 years. So they started looking at it for patients to slow or even stop the progression for brand new patients. And now they're looking at it for more advanced Parkinson's patients who have been diagnosed for at least 5 years. And so it's exciting that they're looking at it on both ends here. And it's a brand new type of medicine, has nothing to do with the carbidopa, levodopa, works in a completely different way. And you can see here that the patients that got placebo, what they're looking at for these fibrils, for these big conglomerates of proteins that happen and that stop this the dopamine from getting to where it needs to go, causes this inflammation. It mentions the neuroinflammation here, and the synapses where these nerves are able to talk to each other. And with these fibrils here, these nerves cannot talk to each other. Same kind of thing with Alzheimer's, with the p-tau proteins. These fibers get in and they don't let these nerves talk to each other. And that's kind of what causes these Parkinson's symptoms. That's what causes these Alzheimer's symptoms, these neural fibers getting together and getting in between these nerves. And the way that these medicines work is it stops this folding at an early basis, so it doesn't get to that oligomerization part, and it doesn't get to the fibril formation part of the progression of Parkinson's. So what we're looking at here is possibly not only stopping the progression, but also backing this up a little bit, maybe getting rid of some of these symptoms. So it's very exciting. This study just started. It's tough with some of these studies because they're looking for a potential subset of patients. And you have to have been diagnosed for over 5 years, and you have to be between 50 and 75 or 80. I don't remember off the top of my head, but there's all kinds of different. You can't have the deep brain stimulation surgery. They're very particular about who they let in and who they let try these new medicines, because they have to be able to prove to the FDA they can't have a lot of different outliers where something can cause an issue with this medicine not working the way that it should, or some sort of a safety issue as well, where it may not be safe for patients that may have other issues going on. So fortunately, it's not easy to get into some of these studies, but it is exciting if you can't get in. And this is definitely one that is an exciting one. This is another type of medicine. This is pretty new. The Pasadena trial is what we're talking about here. It's a 52-week study. Most of them are around that time, but a lot of them, as I mentioned before, will have open label extensions where if you are in this study for a year, you're guaranteed the medicine afterwards. But anyway, it mentions the alpha-synuclein again, where they're thinking that's what causes these Lewy bodies, and where this protein gets in and it doesn't let these cells talk to each other, the cell transmission. And what they saw was at the beginning of this study, it looks like it is able to slow progression of these symptoms. This particular subset they looked at were for the later stages of early onset Parkinson's. So you're thinking, that's pretty specific. So you're looking at early onset Parkinson's, where you're diagnosed before a certain age. And it's patients that are in the later stages of that. But that's how these studies start out. It was a very particular subset. And then, as you saw with the UCB trial earlier, they started out patients just diagnosed, and now they're looking at patients later. This study, hopefully this medicine will progress to patients that have just been diagnosed, or patients that have been that may not have been diagnosed until they turn 70. So, step by step, they'll do different studies on different subsets of patients. This goes into a little bit about some potential limitations of this alpha-synuclein. It may not be stopping this, may not be enough to actually stop the progression. But even if we, even if we can slow it down for a couple of years, 5 years, 10 years, even we can slow the progression, that would obviously be fantastic. And the tough thing about Parkinson's too is that there's so many different things at play with Parkinson's. As I mentioned earlier, so many people can have so many different types of symptoms. That's what makes it difficult to find one medicine that's going to work for everyone. If I go back to this, you can see how this UCB 99 starts out at the very, very beginning of this cascade. That's the key with a lot of these medicines, is to start at the beginning of this cascade to try to stop this from happening instead of trying to work your way back up. And I mentioned here at the end, research has just progressed so fast in the last few years. The computers have gotten better methods of quantifying and qualifying improvement, better scanning as far as like the DAT scans and better lab tests. It's exciting to see the progression just in the last few years, where they've done more now than they've done in the last 20 years. And looking at this alpha-synuclein, looking at different ways to treat as well. This is monoclonal antibody treatment, which I wanted to mention is an exciting new way to treat different things, not only with Parkinson's, but that's all the major new Alzheimer's treatments as well. A lot of cancer treatments, asthma, allergies, osteoporosis, you can read all those. These monoclonal antibodies are exciting because, first of all, most people tolerate them very well. Granted, they are infusions or sub-Q injections, which is kind of a pain, but most people tolerate these very, very well. You don't have allergic reactions. You don't have so many side effects like you do with a lot of other types of medicines. And we're talking even infusions. Patients are tolerating this well because these antibodies are so specific, looking for different proteins or looking for different things. They go right to where they're supposed to go to, and they don't bother a lot of other issues. You look at this medicine, Dupixent, I mentioned here. You've seen commercials for it. You wonder how this one medicine can work for atopic dermatitis, asthma, nasal polyps, COPD, chronic rhinosinusitis, all these different things. And the way that it's able to work for all these different diseases is, think about back to that graphic that I showed, how the UCB medicines work at the very, very beginning of that cascade. It works at the very top of this cascade. So it prevents all these other things from happening. And as far as Dupixent is concerned, they're coming out with new indications all the time through clinical trials. For each new indication, it has to go through clinical trials like we do here, like we're talking about today. But when you stop something early on, you can help out so many different other diseases, especially with these immunology diseases. They can cause so many things down the line, but if you stop it early on, you can really make a big difference. as these clinical trials progress, they'll use more and more patients in here and hopefully be able to address the variability of progression with Parkinson's, as I mentioned before, since so many things play into Parkinson's. It's important to talk about stem cell therapy. That's a new type of therapy that's kind of exciting as well. Stem cells you may not be familiar with, but they have some really important properties. They're found all around the body, but that's how they kind of renew your cells, and not just for maintenance, but for after any sort of injuries. One thing that you think of, I always think of with stem cells is type 1 diabetes. They're working on these stem cells to put in the pancreas to start making insulin again to essentially eradicate type 1 diabetes. It'd be fantastic. And that's one of the things that hopefully they're getting close on working. But you can use stem cells for all kinds of different other things too, including Parkinson's. And you would be looking at those cells that are right at that blood-brain barrier, right at where that dopamine crosses. And I mentioned the developing fetus here. Some people you may know now are starting to save the cord bloods or get the placenta blood and cells from the newborns. Some moms are doing that, and that is in part to hopefully at some point someday take some of these stem cells from that and use them on those children or siblings or anything like that. But stem cells are definitely an exciting new type of treatment. This goes into a little bit about some of the studies that they're looking at with the stem cells. We talked about the off times earlier. The one study that they did showed an average of 2.7 more hours of on time after they used these stem cell injections. So that kind of speaks for itself. And they're starting to enroll another study as well to follow up with these. This is just phase 1 patients here, but the phase 2 will involve a lot more. The phase 1 may have only had 30 or 40 or 50 people. This phase 2 study will have maybe 100, maybe a couple of hundred patients. And it's also promising when, in order to get from phase 1 to phase 2, the study has to show that, first of all, that this medicine is safe and this procedure is safe, and secondly, that it's working, secondly, that it's doing what it's supposed to do. So that's a good sign that it is getting to phase 2 now. Sorry, I am locked up on this screen here. Letting me go to the next slide. Sorry, y'all, I'm going to get out of this for a second. It will not let me keep going. Hey, Diane, I'm stuck on here.
That's
for
okay.
some
Yeah, I
reason.
see that it froze on you. So you may need to close
Mhm.
entire PowerPoint and reopen it. You
Let's
can
see.
and see if that'll work for you.
That is very strange. Sorry about that.
That's okay. It happens. Those technology glitches.
Oh, here we go. Okay.
And then you'll need to share your screen again.
Okay. All right, here's where we were. And let me find the Zoom. Let me see, here we go, share screen. Okay, can you see it?
I can see your screen, but not the PowerPoint.
Okay, sorry about this, y'all.
Oh, that's okay. No worries.
Better?
Yes, it's
See the
back up.
PowerPoint now?
Mhm.
Okay. All right, sorry, y'all. Um, okay, so the next one I want to talk about, and we're getting towards the end here, is a cancer drug that they're using with a monoclonal antibody. And essentially what this is it's two different medicines together. And what they found out was that these these two proteins, these two service proteins, um, got together and up early on the cascade of events, they're kind of they kind of bond with each other, and what happens is this alpha synuclein gets caught in there, and it eventually leads to the cells dying. And what they're looking at is using this cancer medicine with this monoclonal antibody to stop this early on the cascade to keep these healthy cells from dying. And they think that is part of the reason that this dopamine is not being able to get transferred, and part of the progression of Parkinson's as far as with less and less dopamine coming across that you can see in the DAT scans, partly because these cells are dying. But anyway, what it looks like is that this monoclonal antibody, along with this cancer medicine, are able to stop these cells from from dying. So that's a different way of looking at this, a different way of treating, which is great to see because there's so many different areas that to concentrate these treatments on. Um, and medicine like this could have uh, potential effects also on like Alzheimer's and multifocal motor neuropathy, maybe even MS. Myasthenia gravis could work for other diseases as well. So very exciting about looking at these possible cancer type of treatment with this antibody to work as well. Now this just goes into some of the info that you can find, and that is it. So we do have some time for questions if somebody would like to ask some questions or comments.
Fantastic. We do have a few questions.
Great.
One was about the stem cell research, and you did answer that. Another question was inquiring how many trials are currently in phase 3.
For Parkinson's in general, um, probably 100 or more, I would think. With these trials, you can, different places in Sarasota, different places in Tampa. Tampa General does a great job with a lot of different trials. Moffitt even with some non-cancer trials, but of course with a lot of cancer trials as well. A lot of different research centers will have different trials around. Some of them are with smaller companies, which you kind of, all of this has to be approved to get so far to be able to get to us to start recruiting patients. But a lot of these smaller startup companies don't have they just don't get as far as some of these larger companies do. Most of the ones that we work with aren't even based in the US. Lily Otsuka, you're talking South Korea, talking based in Dublin, Ireland, a bunch based in Europe. These are all multinational, multi-country companies and studies.
Thank you. Another question that came in, do you know if they, if LCIPX203 is available in the UK.
No, that I do not know off the top of my head. Um, I do not know that off the top of my
Okay,
head. I'm
no
sorry.
problem.
I can
Another,
I can find out though.
yeah, we can look into that a bit. And the other question, is there any role of the GLP-1 agonist to slow the progression of Parkinson's?
That is something that I heard that they were looking at. Those GLP-1 um, medicines are really, really interesting. We did a study with with semaglutide, with Ozempic here years ago before it was even approved. And what the study that we did with that was for patients that had had a heart attack or a stroke, but had not had diabetes, but were not diagnosed with diabetes, because it was essentially a diabetes medicine to begin with. So what they had us do was for patients that had a heart attack or a stroke, um, give them semaglutide or the placebo and see if that decreased their chances of another heart attack or a stroke. And obviously it worked. Now it is approved for that through the FDA. And it's also approved, as you saw, for so many other things. Obviously, weight loss is a huge thing. And weight loss, they don't talk too much about Parkinson's and weight loss and that, but they're thinking that just keeping the weight down, keeping your blood sugar down, the way that these GLP-1s work, that not only helps with diabetes, but also with all kinds of other things, possibly Parkinson's as well. As far as Parkinson's, I mean, I know how semaglutide works and these types of medicine works. It works in the gut, and um, I mean, one way it essentially makes you feel like you're not hungry anymore. You don't eat so much. You're healthier. You lose weight, or you stay a better weight. Obviously, that's better for all kinds of different things. But as far as Parkinson's itself, as far as the actual alpha-synuclein or the dopamine crossing that barrier, I don't think the semaglutide or any of the GLP-1s have anything specifically to do with that. But I think, long answer short, I think it can help down the line, stopping that progression to begin with. I think it definitely can help, but as far as the off times and that, I have not seen where that is making a difference as far as that's concerned.
Right, thank you. We also have a question, someone who participated in the Parkinson's Expo heard a presentation from a doctor at Stanford University regarding the Parkinson's glove and showing some of the success that was offering. And we're just wondering if there's any information or update on the progress of that becoming available.
Yeah, I don't have any information on that at all. Um, like y'all do a lot of times, what the best thing to do is to figure out what company is doing this, like one of our Alzheimer's trials, and just do a Google search for news for that specific company and see if they have released any new information. Um, and a lot of times it will be released at these like national and international conventions. I get emails all the time saying, this certain company is going to have a presentation at the Parkinson's meeting in Boston in November. And around that time, they may release some more information. But Google's really good at Google News about any new information that's come out, and do Google News for that particular company. And a lot of times you can find it within hours. Within hours, it will come up on a search, and that's about as new as you can get. I do get some information sometimes before other people do, but they're very strict about us not sharing that with anyone until they make it public. And a lot of that is misconceptions until they're able to lay out all the information. But some of that actually, if you can believe it, has to do with people using the stock market. When they find out a new medicine, a new whatever's coming in, and they get some quote unquote insider information that, listen, this is actually working, this is going to come out. Um, you'd be surprised how many people will buy stock like that in these and you know, that stock sure as heck the next week goes, you know, can sometimes double. So I always have to sign things with each study saying that they can check my information and make sure that I'm not doing anything with stocks and my family members and all that. They're very, very strict on that.
Thank you. Well, we certainly appreciate your time and all of this fantastic information. We did record the session today, so it should be available on our YouTube page within the coming days. And if you are interested in becoming part of a research study, you can definitely contact the Bradenton Research Center. And Dr. Folkens had mentioned the clinicaltrials.gov. Where you can see a complete listing, and it is truly amazing how many studies are going on there, and we know how long it can take from phase 1 to FDA approval. So we definitely encourage people to become involved with clinical research so that we can help find new treatments and hopefully a cure for
Oh,
Parkinson's.
and you know, Diane, sorry, I should mention
Mhm.
too, you know, I talk about these smaller companies and the larger companies and the research altogether. A lot of people are afraid of clinical trials. And I want to mention real quick also that we have what's called a IRB, which is an institutional review board. And all of the trials in the US have to be approved by this IRB. And it's a separate board that is above the drug companies, above us, above everyone. And then their job is to make sure that all these trials are on the up and up and everything makes sense. So it's not just some drug company, it's not just us, it's not loosey-goosey by any means. Everything has to be approved by this IRB to get anywhere, and it has to be approved along the way as well. So it's important to note that there is another large company, and anytime that we do a trial, patients have information to that IRB where they can call up and they can say, listen, I'm in this trial, this is the number, and the IRB has all that information. And it's just kind of a way to make sure, it's kind of a watchdog, if you want to say. And they make sure that everything is going along the way that it should.
Perfect. Thanks for sharing all of that too. Great. Well, thank you again for the presentation. Very much appreciate it. Thank you, everybody, for joining us today. Everyone have a great rest of your afternoon.
Thanks, Terry.